All right, everybody. Hello. Welcome to this evening's IPE webinar session. My name is Emily Sprenger. I am an academic trainer for the Graduate Study Support Center, formerly known as the Center for Teaching and Learning. And we are very thrilled to be able to help support our School of Health Professions IPE webinars. Couple of brief housekeeping items. Just know that our webinar is being recorded and we are going to place it in the Graduate Study Support Center webinar section. And I'm just thrilled to be able to introduce two students and one alumni and another student from North Central University and currently National University now, Veronica Shake and Tabitha Myatt. They are fantastic assets and community members to the School of Health Professions, and they will be help moderating the rest of this webinar. So I am going to kick it over to Tabitha so she can introduce our fantastic guest speaker.
Yes, good evening, good afternoon to all of you, wherever you may be. I would like to take the time to thank you for joining us for our monthly IPE session. Actually, this is our first IPE session of the year. So we welcome you. Happy New Year to you all. I would like to take the time to introduce to you one of our very own to kick this new year off for our IPE session, Dr. Cedric Schills, who's an assistant professor for the School of Health Professions here at North Central National University. He holds a Bachelor's of Science in Nursing from Florida State University, a Master's of Science in Nursing from the University of South Alabama, and a Doctor of Philosophy in Nursing from the University of Phoenix. Dr. Schills has over 23 years of experience in nursing. Yay! He has an extensive background in nursing education, leadership, family practice, and primary care. He is an experienced nurse educator and has expertise teaching and facilitating didactic and clinical courses for undergraduate and graduate students. Prior to joining North Central, now National University, he has a National Health Services Corps scholarship. He was a National Health Service Corps scholarship recipient and provided primary care to underserved communities, in addition to serving as a visiting and assistant professor at Capella University, Chamberlain University, and Colorado Technical University. Dr. Schills is a board-certified family nurse practitioner with board certification from the American Nurses Credentialing Center. He holds an autonomous practice license in the state of Florida and is the owner of Mobile Practitioners Group, Inc., a home-based primary care company. Dr. Schills' research interest is in qualitative works, specifically dealing with culturally specific care and the care of underserved populations. He has held several leadership roles that include, but not limited to, coordinating nursing courses, curriculum development, and the development of nursing-specific leadership strategies. He is a member of Sigma Theta Tau International Honor Society of Nursing, Omega Psi Phi Fraternity Incorporated, and several other philanthropic and fraternal organizations that promote health, wellness, and community engagement. Welcome, Dr. Schills. There are a couple of things that I want to share with you this afternoon, this evening, before we get started. A couple of housekeeping items. I just want to let you know that throughout Dr. Schills' presentation, he's going to pretty much give us his presentation in segments because we're going to be talking about preventative care and wellness. So throughout the presentation, we ask that you submit your questions via the chat, raise your hand because we're going to have a stop or pause session throughout the presentation where you can ask questions by section throughout this preventative health presentation. We hope that you guys engage with us, ask your questions. I'm sure it's going to be well-rounded. He's coming to us with a lot of information that's going to help us. So I'm not going to keep rambling because we have an hour and we want to make sure we have time to engage with you and collaborate. Again, ask your questions through the chat. We do have an upcoming session next month that we want to bring your attention to. We have that posted on the chat, as well as we'll make a reminder at the end of the session here with you tonight. So again, thank you so much for joining us. Dr. Schills, I'm going to turn it over to you.
Well, thank you, Tabitha, for that wonderful introduction. And of course, it's a pleasure for me to be here tonight with everyone for our kickoff webinar for our monthly IPE series at National University. I want to thank all of the wonderful staff and all of the wonderful students that help and prepare and make this webinar available to us, to our family, friends, and our university committee. Without further ado, today's webinar is going to be based on preventative health and wellness. With it being the new year, with everyone having, of course, New Year's resolutions related to weight loss, one to exercise now, one to get into better health, better fitness, setting new goals. I thought what not a great time than now than for us not to talk about preventative health at the beginning of the year to kick off everything, to get everybody going for 2023. So I want to say Happy New Year to everyone, and hopefully everyone is having a wonderful 2003. As I proceed in the presentation, we're going to talk about different topics, focus primarily on preventive care. We're going to talk about weight loss, exercise, immunizations, and some cancer screenings. As I go through each topic, I'm going to pause after each one to allow for a little Q&A if anybody has any questions about anything or need clarification about any of the recommendations. So as I go, I'll have Tabitha or Veronica assist with screening the questions, so it can kind of be an engaging discussion rather than just a teaching session. So as I proceed, I'm going to go off camera here. I'll come back on camera once we start the Q&A sessions in between topics. Okay. All right. So again, Happy New Year to everyone. Today we want to get everybody amped and get everybody excited about a healthier 2023. I want to begin by explaining to everybody what preventative health care is. Preventative health care includes disease prevention and health promotion. There are three basic services that are included in preventative health care, and these services are immunizations, screening for early detection of disease and illness, and education and counseling. Now, the difference between preventative health care is that preventative health care is proactive rather than being reactive. And so the things that we'll be discussing today will be screenings for individuals who don't have a disease or who aren't symptomatic and the disease hasn't already been detected in their body. So this is more about screenings and wellness and doing things proactively rather than reactively. We're going to start off with weight loss, right? 2023, I'm pretty sure the majority of us want to lose some weight. All right. So, the first thing for us to know is, what is healthy weight? We all have these lofty goals that we're going to lose. I'm going to lose 20 pounds by February. I'm going to lose 100 pounds by June. But of course, we need to set realistic goals when it comes to healthy weight loss. The recommendations now, healthy weight loss is 1 to 2 pounds per week, for those of you that didn't know. So 5 pounds, 10 pounds, that's not considered healthy weight loss. Typically, if you're losing that much weight, it's typically just water weight and not real weight, real nutritionist weight, all right? So with weight loss, of course, you want to set realistic goals, know your body mass index, and I'll talk a little bit about that a little further. And also, what is your end game? What is your purpose for losing weight, right? Is it for health? Is it for fitness? Is it just aesthetic? Do you just want to look good? Do you want to be, if you're a guy or a lady, you just want to take your shirt off at the pool? What are your goals? What is your end game? What is it for? Is it for, better health, fitness, aesthetics? What is it? Whatever it is, set it and make it realistic. You're going to have some peaks and troughs throughout the process, but the key is to keep the course. Weight loss is, it's simple but complex, right? Calories out have to be greater than calories in, right? The numbers have to equal out. And that's, of course, easier said than done. but it's really just as simple as that. Your calories out need to be greater than your calories in, right? So if you're eating 2,000 calories a day, you want to lose weight, you probably need to burn 2,500 calories per day. All right, so that at the end of that week, you can possibly drop a pound or half a pound during that week. I mentioned in the previous slide about the body mass index. Now, the body mass index is just a rough estimate of the body's fat. It's really not a good indicator, especially in certain ethnic groups, certain individuals, athletes who have larger muscle mass, denser bones. Your older adults, the body mass index isn't really as accurate, but it's simple to do, and it's a good indicator of risk for certain diseases such as cardiovascular disease, diabetes, and some other metabolic diseases that are correlated to increases in weight. And this is your body mass index. You hear a lot about this in your healthcare practitioners' offices, I'm sure. Over my tenure seeing patients, this is a big stickler with a lot of my patients, especially when they get their clinical summary of their visit, and it has they're overweight or they're obese. I've gotten some of the nastiest looks from individuals leaving my office, and I label them as overweight or obese. And so this is how we come to that. Your BMI, how we calculate it, is your weight in kilograms divided by your height in meters squared, right? And that's how we come up with this number. And here at the bottom here, it tells you what determines whether you're overweight, underweight, normal weight, or obese, right? The more on the obese and overweight side you are, the more you're likely to be at risk for certain cardiovascular and certain metabolic diseases. But this doesn't, of course, include your stellar athletes, who are loaded with muscle and are super fit. So these are some of the basic things you need to know about weight loss, right? Make it realistic. Weight loss, you shouldn't lose no more than 1 to 2 pounds per week. All right. Set your goals that are attainable. Don't be discouraged. All right, and set the course. Weight loss, of course, won't come without exercise, right? Sustainable weight loss, you're going to have to include exercise in. All right, there's not going to be much weight loss unless there's exercise, right? And you must adopt exercise, of course, in your lifestyle. Exercise is it's definitely a lifestyle change. Most of us complain about not having enough time to exercise and this and that. But hey, there's 24 hours in a day. We have time. As long as your healthcare provider says you're okay to do whatever exercise it is that you can do, you have 24 hours in a day, you can put it in there, right? Instead of spending 30 minutes on Facebook or Instagram or YouTube, spend that 30 minutes exercising. And now when I say exercise, the recommendations are 30 minutes most days a week, which is 5 days a week at least. So total each week, you want to do at least 150 minutes of exercise, right? And 2 of those days should be weightlifting or resistance training. I know a lot of individuals are scared of weights and resistance training. A lot of women are scared. They don't want to get bulky. But studies have shown that increasing muscle actually increases your metabolism and increases weight loss and fat burn. After you lift weights or do resistance training, your body's at rest. Your body continues to burn calories, and you continue to lose fat even after the workout is done. So don't be afraid of lifting weights or resistance training, right? But of course, before you engage in any exercise regimen, always consult your healthcare practitioner and make sure that whatever it is you're trying to do will work for you, and that you're able to do it, and that you're fit enough for it. Okay. Any questions before I move on to the next on related to weight loss and exercise?
Yes, we do, Dr. Schills. Okay. Why do they recommend to spread it out over 5 days and 30 minutes instead of 1 hour, 1 day, and so on?
All right. So recommending, so it's spread out. So 1 hour, 1 day, it's spread out because you want to do it most days. So you want to speed your metabolism up. So the key is speeding your metabolism up. If you work out 1 day for an hour and you got 6 more days to do absolutely nothing, all that work you've done in an hour, you reversed it. You've undone that work, right?
Oh, wow.
So you've undone that. So you want to do 30 minutes a day. And when I say exercising, it's not, if you're a landscaper, cutting yards and trimming trees, or you're a nurse walking around the unit at the hospital, doesn't constitute as exercise. When I say 30 minutes means 30 minutes of dedicated exercise in which you get your heart rate enough to sweat, right? So work does not substitute for a 30-minute dedicated session of exercise.
Wow. All right. One for the books here. I learned something new every day. All right. So if BMI score isn't always a great indicator, how do we know what is the best weight / BMI for our bodies?
So we wait, and what's the best indicator? So it all depends on your body type, right? It all depends on your ethnicity, your body type, how much muscle you have, how tall you are, how short you are. There are other tests, there are weight circumference tests you can do, some fat calibers, and some different things that you can use to determine how much weight you need to lose. But the BMI gets us close enough to where we know whether or not you're, without doing any very in-depth scientific measurements. And the BMI is close enough to get us where we need to know to let you know that you're overweight or obese. It's quick, it's easy, and it's simple. Most people can understand it, right? But you'll have to consult your healthcare practitioner, and they'll tell you, some of the more in-depth studies and more in-depth measurements you can take to determine what your true weight is. How much fat you have, how much muscle you have, what's your BMR, and things of that nature. It gets pretty complicated, but just for your regular office visits and just for general health, the BMI is a good starting point.
So what are your views regarding intermittent fasting? I have family members that use this method to lose weight.
All right. Intermittent fasting, I don't necessarily agree with intermittent fasting. It kind of tricks the body, and it gives us unrealistic results, and we're not disciplining our minds to continue continue the regimen that we should be doing. You have to exercise every day, and you have to eat right every day, right? At least most 5 days a week. Intermittent fasting, typically you're just losing water weight. So once the fast is over, you're going to go back and drink more water. If you're not eating for 3 days, you starve yourself. Your body's going to hold on to that fat, to that weight, to that water, and then those 3 days are over. You're going to engorge yourself. Then you have to train yourself, train your mind, train your body over time, because the body is a complicated machine. Just by starving yourself or fasting, the body will recognize what you're doing, and they'll hold on to that water, they'll hold on to that weight. So you really got to get the body going most days of the week, so it can't figure out what it is you're trying to do to lose that weight.
Okay. So what role does water play in weight loss? So I think, I hear as well, 64 ounces or more. Some people carry around gallons of water.
Right. So it all depends. Now, water is kind of tricky. You need water to flush the system out, right? So 64 ounces, we recommend 64 ounces, but the true indicator whether or not you had water or not is your urine. When you start to urinate, if your urine's clear, then you've had enough water. If it's yellow, it's strong, then you need more water. You need water to lose weight. You see a lot of the big guys in the gym carrying around gallons of water. They carry them around for different reasons. A lot of them use a lot of supplements, and so they need to flush that stuff out of the system. And of course, when you're working out too, you want to use your water so you can flush all the toxins out. But water, 64 is a good barometer, but the most important barometer is check your urine. If your urine's clear, then you drink enough water.
Awesome. All right, we have another. What are your views on adopting a low-carb diet?
All right, low-carb diets are good. Low-carb diets are good, especially for weight loss. The body converts everything we eat into sugars, and carbohydrates is just like eating cotton candy, right? So you eat a loaf of bread, or you eat some bread at Outback Steakhouse. You may as well go and eat a Snickers bar. So low carb diets, you can't take all the carbohydrates out because your body needs that quick energy, especially if you exercise. You need that quick energy for your body to use during exercise. So you can decrease the carbohydrates, increase the lean meats, and increase the vegetables and the fruit. Low carb diets are good, but you can't be on those for too long because you're gonna need some carbohydrates.
All right, let's see here. One other question. It's a fad going on with this Ozempic, this diabetic medication people are tapping into to lose weight. Is this TikTok feature and all this other, I'm thinking about tinkering with that myself, maybe to give me a good jump start. What is your view on that?
Ozempic, no, unless you're diabetic and you need Ozempic to control your blood sugars, no on Ozempic. Get out there and get these 30 minutes in a day, start eating right, drinking more water, and get it the right way. If you figure this out and really make managing your diet and exercise a real portion of your life, it'll work for you. The weight loss will be sustainable, and you won't gain the weight back. A lot of these quick fixes aren't good. If you're morbidly obese, sometimes we may give you a quick fix for a couple months to get you jump started, but then we want to get you back on this 30 minutes a day appropriate diet type system. So it all depends. I'm not a big stickler into the fad diet.
Awesome. How is adequate sleep? I think we'll give you this one, then we'll go on. How is adequate sleep a factor for weight loss?
Oh, adequate sleep. You definitely need adequate sleep. Body needs to recover, right? So if you're exercising, body needs to recover. You actually, if you're doing resistance training, like I talked about earlier, if you're doing resistance training, weightlifting, your body's actually burning calories while you sleep. So your body has to have time to regenerate and repair muscles before you go back out there and do it all over again. You need sleep. You end up injuring yourself if you don't get enough sleep and you don't get enough rest. So you definitely need sleep. Sleep is important. At least try to get 6 to 8 hours of sleep a night. Good sleep. Turn the TVs off. Turn the cell phones off, and get you a good 6 to 8 hours of sleep at night.
Awesome. Well, we have a few other questions in, but I know for sake of time, we want to get through the presentation. Right. So guys, we'll definitely come back to your questions for Dr. Schills, okay?
There's a lot of good questions, guys. I'm gonna move on so I can get through some of these others, and then as we proceed, if I get to the end, we can go back and answer some of those other ones that you guys have. All right, so we can't talk about wellness and preventative health nowadays without talking about COVID-19, right? I'm not going to get into the particulars of the vaccines. There are like 4 different vaccines now and different recommendations for each. But the main thing in preventing COVID-19, of course, is hand washing. The CDC now has a search engine on its website now where you can check your county's COVID numbers. So you want to track your community trends, right? So if you if your communities have an uptick in COVID, you need to start putting your mask on, start social distancing a little more, and start avoiding crowds and whatnot. So check that out on the CDC website. It's the CDC COVID-19 county check. You can put your county in there and it'll tell you what the COVID numbers are in your county. Also, of course, to avoid COVID-19, do outside activities, right? Keep your home well ventilated. Open your windows, open some doors, and get good air circulating through the home. Wear a mask if you're high risk. If you're already sick, if you're immunocompromised, diabetic, going through some type of therapy or something like that, wear a mask. Stay up to date with your vaccine. So if it's time for you to get a booster, get a booster. Most important thing is follow the CDC recommendations. There are a lot of different opinions on COVID-19 and recommendations, but follow CDC. My recommendation and my advice is follow CDC recommendations, get your vaccines, and get your boosters. Of course, these vaccines, these boosters aren't 100%, right? Just like any other vaccine, you can still get COVID, but you just won't be as sick when you get them. And that goes to overall health, right? If you're naturally more healthy and you get COVID, you'll probably recover quickly, and the side effects from the virus will be less than if you were a person who's not in good shape and you catch COVID-19. All right. So that's my spiel on COVID. Protect yourself, hand washing, do outside activities, avoid those large crowds if you can. All right, I'm going to talk about some vaccines. Adult vaccines. Naturally, all of us already got our kid vaccines, MMR, all that stuff. So I got an adult audience here. So we're going to talk about the most common vaccines for adults that I typically get a lot of questions about. Your flu vaccine, that's recommended. If you're 19 years and older, you need to get a flu vaccine annually. Flu vaccine usually comes out typically in the fall. Early fall flu vaccines comes out. You don't even have to go to your healthcare provider's office anymore. Now you can go to your local pharmacy and they give them out now. So we've made it more easy for individuals to access the vaccine. So, and of course, this is the decreased excuses. I didn't get a doctor, I could get my flu vaccine. Now you can go to the pharmacy and get it. Pharmacy, your Publix, your grocery store, different places like that. So flu vaccine, you should get that annually. All adults ages 19 and up, annual flu vaccine. All right. Pneumonia vaccine. I get a lot of questions about that. Pneumonia vaccine is not due until you're 65. So you're 65 and older, you get your pneumonia vaccine. That's a one-time deal. Unless you get the PCV15, then you'll have to get another dose at least a year after the first dose. But typically, we use the other pneumonia vaccine. So that's a one-time deal after 65. So pneumonia, if you're not 65 yet, don't worry about that. Shingles vaccine has been very popular over the past, has gotten very popular over the past 5 to 8 years. We've been seeing an uptick in shingles in our older adults. And shingles, of course, if most of us, if you were born prior to the 80s, you probably had chicken pox and things of that nature. So chicken pox is what causes shingles. Shingles comes back out. Chicken pox makes us at risk for shingles. And so that's the chickenpox virus still in our body that comes out of shingles. So age 50 and older, we recommend the shingles vaccine. And it's a 2-dose series, and they spread the doses out 2 to 6 months apart. Also, the HPV vaccine, that was kind of controversial about 10 to 15 years ago when they first came out with that. So all persons through the age of 26-year-old should be getting, both men and women should be getting the HPV vaccine. They found out that most of us already live with HPV, and HPV, certain types of HPV is what causes cervical cancer in women. And what was happening was a lot of the men, we were carrying the HPV vaccine and not knowing it, and then passing it on to the women, and it was causing them cervical cancer. So that's how the HPV vaccine came to be. So everybody up to 26 years old should get the HPV vaccine. And it's in 2 or 3 doses, depending on your age at the initial, when you get your initial vaccine. All right. Any questions about vaccination?
Yes. Can you get the HPV vaccine if you're older than 26?
No, they don't recommend it over 26. And the thinking is that by the time you're 26, you probably already have it. You've probably already contracted the HPV, right? So that's why we really start giving it to the teenagers. When you're old enough really to start having sex is when you should start getting HPV vaccine. But by the time you're over 26, most adults have had sex. Most probably already contracted HPV virus. And so that's why they don't recommend it over age 26.
So if you had chicken pox, do you still take the shingles vaccine?
Correct. So what happens is, so when you got chicken pox a long time ago, The virus never really left your body. It lives in your cerebral spinal fluid. And so as you get older, you might get sick, get immunocompromised, and then the virus comes back out as shingles.
Wow.
So that's what shingles.
Okay, so our next question kind of ties into is, so what is the importance of getting this vaccine? I think you just spoke to that, but is there anything that you want to elaborate on?
Right. So the importance of the shingles vaccine, shingles can cause neuropathy. They can cause permanent neuropathy. And neuropathy is like a burning, numbness, fire sensation on the skin. And very rarely an individual will have a shingles outbreak, and they have the burning and numbness and tingling in the area where they have the outbreak, the rash. Even after the rash leaves, the symptoms will still be there, and it'll be, it causes a lifetime of discomfort in some older adults. And so, if you don't want that to happen, and you've had the chicken pox, I advise you to get the shingles vaccine.
Okay. What about if you never had chicken pox?
If you never had chicken pox, we still advise it because you may have had it and didn't know, right? So get it. All right. So you may just not have had the symptoms. You may have not had the papules and the lesions. You may have had a light outbreak and you didn't recognize it, right? So it's still recommended at age 50 and older. But you don't want to get. I've had some patients, some older adults, and they really suffered from having shingles. And shingles can get really bad and real ugly if you're very immunocompromised. It can cause some damage.
Wow. Yeah, I think I'm a twin. So my sister had all the viruses and stuff growing up, from ringworm, chicken pox, measles, mumps. And I guess because of that, I caught everything she had, but I didn't have it as bad. So I think I remember only having like one chicken pox on my body. So I guess I'll go for that shot. Let's see here. No other questions. Did you want me just to circle back to our previous segment and have?
I'll move on. We'll move on to some of the cancer screenings, and then if I finish everything, we can circle back and answer some of the other questions.
Awesome.
All right. All right. So next, we're going to get into some cancer screenings. So I first want to point out that when I mention screenings are for individuals that are asymptomatic and who don't have any symptoms or pain or anything from whatever they're being screened for. So breast cancer screening is in women who don't have any lumps, right? No lumps, no discharge, no any of that stuff. So it's in women that are in other words, they're healthy. The healthy women. So that's what I mean by screenings. All right. If you have a lump, or you have some drainage, or you have some lesions on your breast, and you go for a mammogram, that's not considered screening anymore. That's considered diagnostic, right? So that's different between the diagnostic test and the screening test. Screening tests are for asymptomatic individuals. Diagnostic tests are for individuals who are having symptoms of some sort. All right. So breast cancer. So according to the American Cancer Society, women's ages 40 to 54 should have a mammogram annually. So that's every year. So every year, if you're a woman, ages 40 to 54 annually. Once you get to 55, you can continue to do it annually, or you can do it every other year, right? And screening mammograms should continue in all women as long as they're in good health and expect to live 10 years or more, right? So who knows how long we're going to live, but if you expect to live 10 years or more, continue getting your screening mammograms every year, all right? And if you're over 55, you can do it every other year. Screenings, of course, differ if you have family history of breast cancer. In that case, you'll go earlier. You'll go typically around the same age as whoever your family member had the cancer or whatnot. So if you had a mom or aunt who had breast cancer at 35, you'll probably start getting your screenings in your 30s, right? So breast cancer screenings 40 to 54 annually, 55 and up, you can do biannually. Okay, all right. Prostate cancer screening. So I get a lot of questions about this, and many men aren't aware of this either. But the old school PSA screenings aren't recommended anymore. The research has found that the risks outweigh the benefits of doing PSAs testing and the DREs. So the recommendation now, according to the United States Preventive Task Force, is that men ages 55 to 69 consult their healthcare practitioner on whether or not they should be screened. I, of course, recommend men who are high risk, such as African American men or men who have family members or close relatives with prostate cancer to start. I recommend that they get screening starting in the 40s, 45 PSA screening. But the main precursor for the recommendations is that they were getting a lot of elevated PSAs, and men were getting all of these tests and biopsies done, and it wasn't cancerous, right? Prostate cancer is a low, slow-growing cancer, and typically most men die of old age before they die of the cancer. And so the recommendation for prostate cancer screening via your PSA blood test should be made by the individual and their healthcare practitioner. All right. If you're over 70 years and older, they recommend against PSA-based screenings, right? Because they figure if you're 70 and older, you'll probably die of old age before you die of prostate cancer, due to the fact that prostate cancer is a slow-growing type cancer. But if you have a family history and you're high risk for prostate cancer or breast cancer, you definitely want to start your screenings at an earlier age than the recommendations. So always consult your healthcare practitioner and let them know, of your family history of these types of cancers. All right. Any questions on breast cancer and prostate cancer screenings?
Yes, we do. Do men get breast cancer? Should we do a screening?
All right. Men can get breast cancer, although it's rare, but currently there are no recommendations for screening for breast cancer in men. So if if you're a man and you have some discomfort there, some lumps or bumps, seek the advice of your healthcare practitioner. But at that time, again, that won't be a screening, right? That would be something diagnostic because you got a problem at that time. But currently there are no recommendations for asymptomatic men to do any type of breast cancer screening.
Why is it that at 55, you have the option to do it annually or every other year? Is it because your risk decreased?
Correct. We're talking about breast cancer screening?
Mm-hmm.
Correct. So depending on your previous mammograms, exactly, your risk decrease. Your risk decrease as you get older, research has found, and then your chances of dying from breast cancer decrease also as you get older, because again, we consider you may possibly die from old age versus the cancer and all of the discomfort that'll come with all the testing.
Wow. So why is a mammogram still a gold standard, and why hasn't technology evolved and developed equipment with less radiation?
Now, that I can't answer. Right now, the mammograms are really pretty good at detecting suspicious lesions in breast. Of course, you get a mammogram that has something suspicious for cancer. They'll then follow up with a biopsy, and really the only true way of determining any type of cancer is a biopsy. That's the gold standard for determining whether or not it's cancer. The mammogram is just a screening, right? It's just a screening, but they're still working on some new advances in technology to your blood testing, your BRCA testing, and some genetic screenings that you can do with blood to help detect, for cancer. But right now, the mammograms, if women are going, like they should annually or biannually, it's doing pretty well at picking up cancer in women.
Awesome. So what is the most effective prostate exam?
Right now, well, screenings, none of them have, research has found that none of them are really that specific to prostate cancer. So there's really, at this point, the PSA is it if your healthcare practitioner thinks you need to do it. The DRE is something totally different. The digital rectal exam, that's something totally different. And that we usually don't do that anyway unless there's a elevated PSA. So the DRE is a little different. But right now, we don't really have a gold standard. Research and science hasn't really come up with a gold standard now for prostate cancer detection in men. But there's one thing for sure: the African American men should definitely talk to their practitioners or their doctors about screening. And PSA right now is the only thing we got.
Okay. So there's a lot of discussion surrounding prostate cancer, but none on testicular cancer. Should conversations around that disease start at the age of 15 in young boys?
Testicular cancer, the numbers aren't there yet, so they don't have any recommendations. When you do your physical exams in your younger boys, your younger men, your younger athletes, we use the screen for testicular cancer. Also, when you see a healthcare practitioner on your annual visits, if they deem that necessary, they can screen you for testicular cancer at that time as well. But right now, there aren't any recommendations right now for men to screen for testicular cancer. It's not as prominent as prostate cancer is in certain men.
Is it important for women to request a neck shield to avoid radiation when doing the mammogram?
No, the radiation is really not a problem. I think that's a misnomer with the radiation exposure. Although we do get, women do get exposed to radiation during mammograms, they haven't identified any significant risk that proves that the radiation during mammograms is causing any untoward problems. So I wouldn't be concerned about the radiation.
Okay. Do you recommend a mammogram for stage 4 breast cancer?
No. So by the time you're at stage 4, we already know you have cancer, so you don't need a mammogram, right? So mammogram is a screening test. So you're past that point. If you got stage 4 cancer, then you have to seek the advice and the treatment of a oncologist for that. But the mammogram is screening. It's screening for undetected cancer, asymptomatic, undetected cancer that we would have not otherwise known was there because the woman is asymptomatic. But if you got stage 4 cancer, it's a whole nother ball game. You should be talking to an oncologist at that time. All right, I'm gonna move on for the sake of time. I think we got 15 minutes. All right, so colorectal screening, cancer screening. So colorectal cancer screening should begin at age 45, all the way up to age 75 in both men and women. If you have a family history of colorectal cancer, the screening should be at age 40 or 10 years before the age of the person in your family who had it, right? So if I had a family member that had colorectal cancer at 50, I should start getting my colorectal cancer screenings at 40. So that's what they mean there. So men and women should start getting their colorectal cancer screenings at ages 45 to ages 75. Some of the screening tests, if you're going to your practitioner or physician regularly, they should be giving you these they call them fecal occult blood tests, stool cards, where you put a bit of stool on there, and test the stool for blood. If the blood is there, then we go into some more complex, testing to determine your risk for colorectal cancer. But I got listed here some other tests. You can do a CT with colography. We don't really use that often. A flexible sigmoidoscopy, you do that every 5 years. But the big thing everybody knows about is a colonoscopy screening. That's every 10 years. If you hadn't had your colonoscopy and you're over 45, I highly advise you to go and get that done, especially if you're in high risk ethnic groups, such as if you're African American or in some other ethnic groups. I highly recommend that you get your colon cancer screenings. Go and get your colonoscopy, or at the very least, do the fecal occult blood test. The Cologuard is good too. That's pretty popular now, where they mail you the kits at home. You put the stool in the kit and you email it back to them. So that's good as well. But there are several tests that can be used to detect colorectal cancer. But for all adults ages 45 to 75, you should be doing those screenings. All right. If you're over the age of 76, they say to consult your healthcare provider to assess the risk versus benefits. Again, that's one of those deals as if, colon cancer is a slow growing cancer as well. But if you're 76 years old, we think you'll probably die of old age before you die of colon cancer, or there are considerable risks of puncturing the colon during the procedure. And so you have to outweigh your risk versus benefits when you get age of 76 and older with your colorectal screenings. Now, don't get this mixed up with diagnostic tests, right? So if you're over 76 and you're having blood in your stool or you're having pain, then you go and get a colonoscopy. That's a diagnostic colonoscopy. But if you're fine and you're 80 years old, there's really no need for you to go get a colonoscopy if you're doing okay. All right. You just talk to your healthcare provider and they'll assess your risk versus benefits, and then they'll determine whether or not you need to have that done. All right. Cervical cancer screening, right? So women ages 25 to 65 with a cervix should be having colorectal screenings. If your practitioner is doing HPV testing, they should be done every 5 years. And the National Cancer Institute recommends the HPV testing every 5 years. If you're doing HPV and the Pap co-test, that's every 5 years. And if you're just doing the Pap test, that's every 3 years. Women over 65 and older, they can stop cervical cancer screenings if their prior cervical cancer screening tests were normal. So you can stop. So if your previous PAP or HPV or co-PAP test was negative after 65, you don't need to have any more colorectal screenings. All right. Now, again, if you're a woman who had a hysterectomy, you don't have a cervix, then there's no need for you to get colorectal cancer screening, right? Because the cervix isn't there. I'm sorry, not colorectal, but cervical cancer screening, because the cervix isn't there. So if you had a hysterectomy, no need for a PAP or HPV test because the cervix isn't there. And now that doesn't mean your healthcare practitioner is not going to go down there and do pelvic exams, because we're looking for something different then, right? So you go in. So I've had some women say, well, I go in and I get a pap smear every year. No, you're not getting a pap smear every year. They're doing a pelvic exam. They're doing some other testing and some other screenings at that time. They're not actually screening for cervical cancer at that time. All right. So the recommendation is 25 to 65 every 5 years if you're doing HPV testing. And like I talked about before with the HPV vaccination, there are certain types of HPV that cause cervical cancer. And so that prompted the vaccination. And that's why they recommend the preferred test is the HPV test every 5 years versus just the PAP test alone every 3 years. Okay. All right. And then lung cancer. This will be my last one here. So lung cancer. Lung cancer is the second most common type of cancer in the United States, the leading cause of cancer death in the United States. All right. Of course, cigarette smoking, we all know that cigarette smoking is the #1 cause of lung cancer. And of course, lung cancer is caused by environmental allergens, pipe smoke, and cigar smoke and all of that stuff. I put this in here because I've been seeing an uptick of cigar bars going around, these vape shops, the hookahs, and all of those things. Just want to remind everyone that even though you're not inhaling, you're still putting yourself at increased risk for lung cancer. So if you're going to do those things, I know they're novel, they're cool now, but of course, do those things in moderation. So you can get cancer from cigar smoke, but cigarettes, of course, is the leading cause. All right. If you want to quit smoking, if you're a current smoker and want to quit smoking, 1-800-QUIT NOW is still available, and the CDC has a bunch of resources to help individuals who are addicted to nicotine to stop. They even got some free medicine. They have free nicotine gum and free nicotine patches. A lot of different things you can do nowadays to help you stop smoking. All right. Lung cancer screening is typically not done, but since we're talking about screenings, you can do an annual screening if you're an individual who's been smoking for several years. If you got a 20 pack year smoking, and then there's some different CTs that they'll do the screening for lung cancer, but that very rarely happens. But since I was on my soapbox about cigar smoking, I kind of threw that in there. All right. And so just to wrap things up, encourage others to see their healthcare provider for screening, right? Attend healthcare provider visits with family and friends. We all have those older family members, or those of us who've taken care of our older parents or grandparents. Go to those visits with them. When they come back, they'll tell us one thing, but the doctor or the practitioner told them another thing. So sit in there at those visits, right? Sit in there at those visits so you'll get the right information and you'll know the right thing to do with them. All right. If you're married, schedule the screenings for your spouse. All right. I know most men, we don't want to go because we're more reactive than proactive, right? So if your wife scheduled an appointment, hey John, you got a doctor's appointment next week, right? Give them don't have them opt out, have them opt in, don't have them opt in, have them opt out. So schedule that appointment for him and just tell him he has an appointment, and more than likely he'll probably go, hopefully, right? Express the importance of prevention and screenings and to the youth. Of course, your HPV vaccines, all of your well child vaccines and all that stuff. Make sure those things are getting done in your kids and in your community, right? Disseminate facts and not myths or folklore, right? Any recommendations or things that you disseminate, make sure it comes from reliable sources. CDC, American Cancer Society, anywhere. Facebook, Instagram, all those places. Those aren't good places to find good evidence-based information about medicines, right? So get your information from good, reliable sources. And last but not least, share your positive experiences with screenings to your friends about your healthcare provider, right? A lot of individuals don't like to go because, they're scared, it's painful, they got to draw blood, they got to, I got to do this colonoscopy. But, share your positive experience. Oh, it wasn't that bad. I'm glad I went. It wasn't as bad as I thought it was. I'm glad I went. Look what they found. I would have never known I had. So share those experiences and encourage your family and friends to be proactive about their health and not reactive about their health. Because by the time it's reactive, then we got big problems, right? You're going to spend a lot of money. All right. And that is it. And Tabitha, I think we still got some time for some questions. We got about 5 minutes if you want to take maybe one or two, and then we can wrap it up.
All right, I'll try to go through the ones that we have here really quickly. Let's see here. So can internal rectal hemorrhoids bleeding cause colorectal cancer?
No, they don't cause it. However, if any area, especially in the colon or those types of areas, if you have chronic inflammation, it'll make you more at risk for cancer. So it doesn't cause it, but if you're having some rectal bleeding, there's probably something going on there. It'll make you're at increased risk for colorectal cancer. So I advise you then to seek out the advice and an evaluation from your healthcare practitioner.
Okay. So why don't they do screenings for lung cancer on smokers and former smokers or people who grew up in homes with smoking parents?
It's just the test, to be honest with you, the tests are expensive. CT scans are very expensive, right? They are very expensive. And so with lung cancer, the preventive treatment for lung cancer is counseling, right? So remember the 3 parts: there's immunization, counseling, and screenings, right? And so the primary mode of prevention of lung cancer is counseling, right? Me telling you not to smoke. You know, if I got a smoker, every time you come to my office, and you're smoking, hey, you need to cut back, you need to cut back, you need to cut back. And you know, my hopes is one day you'll stop, right? But the CTs, they cost a lot of money. They're very expensive to do, and most people can't afford them. And so that's why you won't get any screening. But the counseling and the counseling and those resources that they have at the CDC and other places are the main interventions to decrease smoking and lung cancer.
Awesome. All right, I'll give this last one here and then we'll wrap up. I've received 2 doses of the vaccine for COVID. Should I get the booster if I'm at high risk?
Now, if you're high risk, you definitely need to consult your healthcare practitioner, right? Because I don't know what particular disease you're talking about and why you're high risk. So if you're high risk, always consult your primary care provider before you take the vaccine, right? You know, so I can't make any recommendation on that. But yeah, if you're high risk, before you get the booster, consult your primary care practitioner because they're more familiar with your case and they can direct you better than I can.
Awesome. All right. Thank you so much, Dr. Schills, for this wonderful presentation. Very informative. And thank you all for joining us today for this informative session. Let's keep this conversation going. I know we have the comments, and we ask that you guys drop by and shoot some questions related to preventative healthcare and screenings within the comments. And Dr. Schills, we're going to tag you for helping us keep those questions answered and provide some resources for us so we can be better at being proactive to prevent any diseases, hopefully, in our healthcare and support family members and friends throughout the community. Without further ado, I want to just remind you guys that we have our next session next month. We have Oak Street Health presentation coming to us on February 23rd, 4 p.m. Pacific time. Brianna Clear is going to speak to us on population health. So we ask that you guys govern yourselves to the announcements on your portals at National University or Central University, and also in the Commons. Register, attend the webinars, and come on out for your monthly IPE sessions to receive some very informative information. We thank you all. Again, any questions that you did not receive responses to, please drop them in the comments. This webinar will be recorded and posted. We ask that you take the time to review it again. And if you have additional questions for Dr. Schills, reach out. Thank you everyone so much for your time. We look forward to seeing you next month. Take care.